The number one job of an elected official is to be able to communicate, and to have that taken from me would have been catastrophic. In July of this year, a neurologist said to me, "We've discovered a very large mass inside your brain. It's not something we can even remotely consider operating on here. You've got to find somebody that can do this. There's a very good chance you're never going to be able to speak again." What good is a mayor if you can't communicate? I had talked to doctors in Boston, some of the best hospitals in New York City. More than one physician pulled me aside and said, "There's only one guy that can do the surgery in the world, and it's Dr. Robert Friedlander at UPMC."
What's special at UPMC is the combination of the very best technology and very expert hands to be able to take care of these complex tumors.
I think I've said it before, of just how grateful I am to be alive. I'll never forget it. Look, I didn't choose to have a brain tumor, but I did choose UPMC.
Good morning, and welcome to EMS Update 2021. Thank you for being here with us today on this early morning. Our first presenter in the morning is Dr. Owen Traynor. Dr. Traynor comes to us from St. Clair Hospital in the Pittsburgh area. He's a graduate of the University of Vermont College of Medicine, and is a former EMS provider in the city of New York. For those of you that have attended us previously in EMS Update 2019, you've seen Dr. Traynor's presentation on Things Aren't Always As They Seem. These are interesting cases that have happened since then and follow-ups with that. Dr. Traynor, welcome.
Thank you very much. I appreciate you all being here and looking forward to sharing the next hour with you and enjoying it. I'd like to start off first with this video, which I think captures the idea of things not being as they seem. So things aren't always as they seem. Today we're going to be presenting 4 cases, and you might be tempted to take notes. I would say it's not necessary. I do have a handout available for you. I would recommend, though, that you don't look at the handout until we're done, because I'm going to present cases for you, and it'll ruin the surprise. In this talk, I would hope that you would act as if you really were caring for this patient. Now, I know that when somebody's presenting interesting cases to you, that the person who complains of left shoulder pain doesn't have a shoulder injury like you would expect. In real life, you don't feel like people are trying to fool you, however. So please act like this is a real case and you're the real providers taking care of this patient. But one more thing before we get started. During the interview, or during the introduction, you learned that I was a New York City paramedic, but before that I was a bartender as well. And you know, if you attended last session, that I once had a patron come in and ask for 3 pints of Guinness. I brought the pints of Guinness over, and he picked the first one up, took a sip, put it down, picked up the second pint, took a sip, put it down, the third pint, a sip, put it down, and he drank all 3 just like that and asked for some more. So when I came over, I said, you know, we have plenty of Guinness, we're not going to run out. And he said, oh, you don't understand, I'm from Ireland, and I have 2 brothers, and we were very close. And one of my brothers moved to Sydney, Australia, and I came here to the States, and we promised whenever we'd have a drink, we'd have a drink for the other 2. So that was Sean, and he was a wonderful guy, and I got to known well over the years, and one day he came in and asked for 2 pints. So when I brought them over to him, I said, "My condolences." He said, "What? Wait, no, everything's okay. I just joined the Mormon church and had to give up drinking." So I wanted to update you about Sean. I'm afraid I have some bad news. He was very sick, and I was at his bedside when he passed away. I had just gotten there. I'm standing by the bedside talking to him, and suddenly he gets very agitated. He starts turning cyanotic. I didn't know what to do. I rang the code buzzer, and he was trying to say something I couldn't understand, and there was this notepad by the table. I passed it to him, and he wrote his last words, and he passed away, and he couldn't be resuscitated. But I have the note that he wrote to me, his last words. I'm sure it's important. "You're standing on my oxygen tubing." So, no, things aren't always as they seem. So let's do case number 1. This is a 41-year-old female who presents with 3-day history of nausea, vomiting, and diarrhea. She says it's been about 3 days since she's been able to eat. She feels lightheaded and dizzy. She has a headache and some right upper quadrant abdominal pain. She says that her family was in town during the Christmas break. This is a pre-COVID case, and many members of her family developed that gastroenteritis GI bug with vomiting and diarrhea. So she thinks that's where she caught it from. She's been taking some Tylenol, drinking Gatorade. Nothing's helped, so finally she's come in. She says her last menstrual period just began before this illness began, and the pain in her right upper quadrant is intermittent. So let's move over to the history of the past medical history. She had problem with the disc in her back and had a spinal fusion surgery about 5 years ago. She does have a history of endometriosis, and just recently it was time for a PPD, the biannual test, and hers was positive. She is working as a nurse in the local primary care office, and she's been referred to infectious disease to find out what needs to be done about that. When we look at her med list, she doesn't have any prescribed medications, but recently she tried to quit smoking using Chantrix. She's been taking Tylenol, no drug allergies. When we meet the patient and we do our initial exam, we find that she appears ill. She is not febrile. She has a heart rate of 120, and it's regular. Her BP is 136/74, and her respiratory rate is 14 and non-labored. Anything jump out from those vital signs? Sometimes I believe there are a lot of clues there, and we might be too busy to think about them. But I bet you notice the heart rate is fast, and because of that, you have some ideas about what you might find and what you might do for this patient. So we're worried about the heart rate. On her exam of her head, ears, eyes, nose, and throat, we find her to show no evidence of trauma. Her mucous membranes are dry. Her neck is supple. She doesn't have any JVD. The lungs are clear to auscultation bilaterally. Her heart exam is regular but tachycardic. There are no murmurs. And when we palpate the abdomen, we find that she's got some mild epigastric tenderness. Her extremities have good pulses, no edema, and she is alert. So this is a perfect time to think about what might be wrong in this patient. Certainly, you were probably working that year when we had a load of patients with nausea, vomiting, and diarrhea. So we could put gastroenteritis at the top of the list. It was a time in which there was a norovirus outbreak, and there were many, many sick people requiring many different, many large boluses of fluid. So that's on there. Think any other things? Appendicitis? Probably not. Probably not cardiac. So I'm thinking that's probably what we're thinking most of the time now. So the patient's in the emergency department, and you know how the ED is. They do these things: some IV normal saline, some Zofran IV, some Dilaudid for pain, and they send labs. So following that intervention, she's starting to feel somewhat better, and now we turn to the lab reports. So the CBC is within normal limits. So her white count is not high, she's not anemic. Her electrolytes, like sodium, potassium, are within normal limits. You know, we worry about those things when somebody's got GI fluid losses. And then we get to the renal test. Creatinine is 2.6. And the normal range is listed there, 0.8 to 1.4. So something's going on with the kidneys. Could it be dehydration? It may be. Amylase and lipase are those tests that look at the pancreas. She was tender in the epigastrium, and they're slightly elevated. We usually look for 3 times the normal value to say pancreatitis. And then this is one of the liver tests, the AST and the ALT, and normally they're under 55. Yikes, right? What the heck's going on here? This is probably not what we thought initially. So not gastroenteritis. So if you're the physician, you're going to look pensive and then order the CT scan of the abdomen pelvis, and you're going to go back to talk to the patient. So what would you ask this patient? You have something on your mind, and the question that you probably would ask is, how much Tylenol did you take? She's a nurse, right? How much Tylenol would she take? 4 or 5 extra strength tablets at a time, 5 or 6 times a day during my period. So let's go to round 1 of our pop quiz. This round 1, you could win a lovely dinette set, so I wish you luck with it. So question 1, what is the manufacturer's recommended maximum adult daily dose for Tylenol? And the choices are simple, either 2 grams, 3 grams, 4 grams, or 5 grams. So what do you think? You can vote for A, you can vote for B, C, or D. Lock in your answers in your imagination. So the correct answer is actually 3 grams. We know that there's toxicity due to Tylenol, and limiting the ingestion means that we're likely going to be safe and not have any bad side effects. So now we come to the part about people take overdoses. What's the maximum single dose that may result in toxicity? It's a weight-based dose. So it either could be 70 milligrams per kilogram, it could be 140 milligrams per kilogram, it could be maybe 210 per kilogram, or 280. Now you're doing that math in your head. I take 650 milligrams, that's 2 Tylenol. Sometimes I take the extra strength, that's 1,000 milligrams. And I weigh, and you're doing the math, what do you think it is? Is it 70, 140, 210, or 280? If you lock in your answers, you'd be correct if you locked in B, 140 milligrams per kilogram. So if you imagine a 70 kilogram person taking 140 milligrams per kilogram, now you're up to about 10 grams. So it would be difficult accidentally to take a single dose and be toxic. Now the interesting thing about Tylenol for overdoses is that it has phases to it, and different symptoms and signs appear during different phases. Let's look at phase 1 of Tylenol toxicity. That's often the phase that you and I would be involved in the care of these patients. So this is during the first 24 hours. The chief signs or symptoms of this phase can include A, abdominal pain, B, nausea and vomiting, C, choices A and B, or D, none of the above. So you wouldn't be surprised probably if they had abdominal pain. You know it bothers the liver. Do they get nausea and vomiting with it? You wouldn't be surprised. Could it be both of those? Or is it none of the above? Lock in choice D for none of the above. The first 24 hours is a quiet time for the overdose. And this is why when somebody says they've taken an overdose and they feel fine, that I don't stop worrying. During stage 1, the first 24 hours they're asymptomatic. Near the end, they might have nausea, vomiting, and they might have malaise. Stage 2 starts from day 2 to day 3, and then they start to show signs of liver failure. Right upper quadrant pain develops. Those 2 labs that we saw, AST and ALT, start to go up. If you measure coagulation tests like INR that we would do when we're looking at people's Coumadin, that goes up because the liver is failing. It's not making the clotting factors. The kidney function seems to rise then. We had a creatinine of 2.6. And stage 3 occurs at 72 hours to 96 hours. That's the maximum time of hepatotoxicity. and that'll be when you have your highest renal failure, highest liver failure, and typically death occurs during this time, 3 to 5 days after the overdose. And these folks get cerebral edema, they get sepsis, multisystem organ failure, hemorrhage, and adult respiratory distress syndrome, all things that are terrible. Stage 4 begins at day 4 and goes up to 2 weeks, and it's the recovery phase. So if you make it past those first 4 or 5 days, you can get out of the woods. So let's go back to our regularly scheduled program. Here's the CT scan and an ultrasound. And on the CT, they said, maybe there's gallbladder sludge, so that's why the ultrasound was done. And that didn't really help us, did it? So I want to introduce to you something called the Rumack-Matthew nomogram. This is the nomogram that we use when we order a Tylenol level to see if this is likely to be toxic. And so this compares the Tylenol level on the y-axis to the hours post-ingestion. And you can see the graph begins at 4 hours. So if somebody's taken an overdose and they come in right away, they're going to be before the 4-hour mark. And so measuring a level then is not going to be helpful. We don't know where it fits on this. So after 4 hours and up to 24 hours, we can plot their result. And you can see the original line for toxicity and the treatment line are very close to each other. So if they're over the treatment line or above, we're going to treat it. And let's see this patient's plot. Wow. So even though she is way out there, it still looks high. So what do? We use acetadote, which is the antidote for Tylenol. And it's based on weight, how we administer it. Not important for you to know that now, but that's the thing we do. And of course, folks have figured out ways to look at people who have acute Tylenol ingestions. And as you can see from the graphic, it's kind of involved, but there's a much simpler thing. It's called the Poison Control Center. Here in Allegheny County and in Pittsburgh, this Poison Control Center is affiliated with the UPMC toxicology program. And so anytime, day or night, you can get a hold of a toxicologist. So that's the recommendation I would make. Now, if somebody has taken a chronic ingestion, not just one 140 per kilo dose, but like our patient did here, multiple overdoses over multiple days, very complex. And once again, just call the Poison Control Center. The folks who work there, the technicians, are fabulous. And if you need the toxicologist, they're there at your beck and call. So what happened to our patient? She got admitted to the hospital, got the acetadote, and the next morning her liver function tests were better, but her creatinine was not. And so this is when we said we need a higher level of care. So she was transferred to the Intergalactic Medical Center at UPMC, where the toxicology program is housed. And fortunately, she survived, her liver healed, and her kidneys got better. So this case number 1 today, has a pearl. And the pearl is that you should carefully evaluate people with potential overdoses of acetaminophen or Tylenol, because phase 1, they all look good. So the fact that they look good is not comfort enough. This would be a perfect time to ask questions. What we're going to do, though, is save questions for later, and many of the questions might be answered in the handout. Let's move on to case number 2. A woman passed out. EMS has been dispatched to a woman passed out, and you find a 72-year-old female who looks well sitting on the grass in a park. She tells you she passed out but feels fine now. So you start out with, hey, what were you doing when you passed out? So she says she was out for a morning walk. She had a sudden pain in her side and fell into some bushes, but not those bushes, these bushes. I spared no expense on animation, as you can tell. So it isn't just a walk in the park, is it? So the history of the present illness: out for a morning walk, sudden pain left flank, passed out, fell into the large bushes like I mentioned, awoke on the lawn short time later, feels okay. This has never happened before. She's well before this happened. She didn't have chest pain. She didn't have palpitations. She didn't have shortness of breath. She doesn't have any history of GI bleeding. She's not been lightheaded, no fevers, no chills, no urinary symptoms. So let's look in the past medical history. It might go something like this. Do you have any medical problems? No. Do you take any medications? Yes. You've been at this patient's house. This happens a lot. So when you look at the med list, you see Inderol, Combivent inhaler, Lasix, and a potassium supplement. No drug allergies. And so I think that if we're doing the past medical history and decoding it, what we do find out, the real past medical history, is hypertension, COPD, she's had a cholecystectomy, she's had a hysterectomy. Now, before we do the physical exam, I just want to stop and ask this question. What happened to this patient? Passed out, and so we would call this syncope, which brings us to round 2 for large screen television. Here we go. Which of the following differentiate a seizure from a syncopal episode? You know, sometimes it's difficult to do this. So is it tongue biting that lets you know that this was a seizure and not syncope? Or could it be clonic motor activity, muscle contractions? Is it choice C, incontinence? Or could it be the presence of a post-ictal period? So think about the syncope cases you've had and the seizure cases you had, and lock in your answer. And you should have chosen the post-ictal period. People who pass out sometimes bite their tongue. People who have seizures can bite their tongue. If you're passing out and nobody lets you get to the ground and get flat, often you'll have clonic motor activity. And that's sort of the most misleading thing. It can even happen if you're donating blood. 12% of blood donors will have clonic activity when they're passing out. 20% of people who get ocular compression, so if that's one of your signature wrestling moves, pushing on the eyes, 20% of people will look like they have a seizure as they pass out. If you're into testing people for orthostatic hypotension and do a tilt table exam, 90% of the people who syncope after hyperventilation, followed by squatting, followed by fast rising, and a Valsalva maneuver. You're really doing something weird on Friday if you're doing these things. And finally, incontinence can happen on either of those things. So I don't know if you think about what happens to your syncope patients after you drop them off at the hospital. This question looks at that. The 6-month mortality rate for patients with cardiac-related syncope. What happens to those folks? Well, is it A, less than 1% will die, or is it B, 2%, or C, greater than 5%, or greater than 10%? What do you think? The answer is surprising that it's as high as 10%. Cardiac-related syncope is the most dangerous because it indicates the patient may be at risk for sudden death. This is the syncope that's related to arrhythmias. This is the syncope that's related to ischemic heart disease or valvular heart disease or cardiomyopathy. It's not the syncope of I was dehydrated and I stood up quickly. So it's that particular class of syncope. Which brings us to which is the most common type of syncope? Is it syncope of unknown cause? Could it be neurally mediated syncope, cardiac-related syncope, or orthostatic syncope? Well, if we're looking at this, I bet you're thinking it's not going to be cardiac-related syncope because you don't hear a lot of your patients have died. Is it choice A, syncope of unknown cause, because the doctors you bring the patients to don't know what they're doing? I hope that's not the case. Neuro-related, orthostatic? Correct answer is syncope of unknown origin. The neurally related is related to inappropriate vasodilation or bradycardia, sort of the vagal syncope. Orthostatic, you know, usually in dehydrated people or people on medications that prevent the reflexes of vasoconstriction and tachycardia. And we already talked about cardiac syncope. So back to the regularly scheduled program. So now we're going to do a physical exam. And of course you find she's alert and oriented. Airway, breathing, circulation are normal. The neuro exam is normal. normal. There's no evidence of trauma. Her heart rate is 72 and regular. Respiratory rate is 18. It's non-labored. BP 126 over 80. Pulse ox 94% on room air. Is there anything here concerning? It looks almost too normal, doesn't it? So you move into your secondary assessment. Head, ears, nose, and throat. No traumatic. Pupils are equal. Neck is non-tender. It's supple. The lungs are clear. Extremities have good pulses. Neurologically alert and oriented. Doing well. You hook the patient up to the monitor, and you see she's got normal sinus rhythm. There's no evidence of ischemia. Glucometer is 140. So what are you going to do? I bet you would do this, this, and this. And on the way in, your patient remains stable. So she gets to the emergency department. Oh, that's the wrong slide, sorry. She gets to the emergency department, and if you could ask one question, and it was asked on arrival in the emergency department. No, not that question. I know somebody asked you that on patients you bring. The question I asked was, has anyone ever told you that you have an aneurysm? The answer was a resounding yes. Here's her CAT scan. 7 centimeter AAA and leaking into the retroperitoneal cavity, which brings us to round 3 for a vacation to Cancun. And you will be staying in the Ted Cruz suite. Lucky you. Bring extra batteries. So what size AAA has a 5-year risk of rupture of 25 to 41%? You may have heard that when people have AAAs that they get surveillance, and at some size they have surgery. So is it less than 2 centimeters? Is it 2 to 3 centimeters? Could it be 4 to 5 centimeters? Or is it greater than 5 centimeters? Lock in your results. And you should have chosen 5 centimeters as the time to get it done. How good are we at detecting AAAs in asymptomatic patients? Does our physical exam identify 90% of those folks? Is it B, 75%? Could it be C, 50%? Or is it D, less than 25%? I won't feel bad if you guess A because you're confident in us, and I'll be embarrassed if you select D. No one knows what your answer is, but lock it in. And the correct answer is 50%. So a physical exam is not great. That means if you feel it, it's there. If you don't, it might still be there. So it turns out, since our physical exam is poor at identifying these, you're not surprised that 50% of the symptomatic people are even misdiagnosed. So that means they're leaking a little bit. So what's the most common incorrect diagnosis for that person? Do we tell them you have a kidney stone? Do you have appendicitis? You just have acute back pain? Or do you have diverticulitis? What do you think we tell them when we're wrong? Lock in your answer. I hope you chose kidney stone. People with kidney stones get back or flank or abdominal pain. That's what people with aneurysms get. 50% misdiagnosed on the initial presentation. It's often associated with syncope, and if we miss it, 80% will be dead in 1 year. The classic triad of a ruptured AAA is back pain, hypotension, and a pulsatile mass. 10% of people will have flank pain and asymmetric pulses. So something to think about. If the AAA ruptures into the peritoneal cavity, that's the abdominal cavity, that patient dies very quickly because there's plenty of room for blood there. If it does rupture into the retroperitoneal space, that's really a potential space, and the bleeding can be tamponaded. If your patient ruptures the AAA and they make it to the hospital and they're alive when they arrive, only 50% of them will survive. And if they get theirs repaired, 67% will live at least 5 years. So this is an important thing to diagnose. So back to the regular program, a woman passed out. She went to the OR promptly for emergency repair. I had asked her if she had wanted to, why didn't she get it repaired? And she said she wasn't going to get it repaired, but now that it ruptured, she wanted to have it fixed. She went to the OR, but unfortunately, she died during the operation. So the pearl today for this case is be suspicious of leaky AAAs in elderly patients with flank pain, back pain, or syncope. Any questions? We'll hold them to the end. The next case is entitled allergic reaction. When you're working in the emergency department, it's late in your shift, you're looking for a good last case that you can do and wrap up in a short period of time. And so you're looking for that one, and I see this chart that says allergic reaction. I'm good at allergic reactions. I know about Benadryl, Pepcid, Solumedrol, and Epi. What could go wrong? So here's what the patient looks like when you walk in the room. Probably not allergic reaction. 45-year-old male who appears anxious. He sure does. It began yesterday. Very anxious, painful muscle spasms in his legs. It was so bad that he really felt like he couldn't walk today. Nothing he tried made it better or worse. There's no radiation or referral of the leg pain. He says it's moderate to severe. He's got mild anxiety beginning 7 days ago. His psychiatrist increased one of his meds 4 days ago. He's not having fevers or chills, no headache, no vision changes. He is kind of shaky. He's had a non-productive cough for 5 days, but he's not short of breath. No chest pain, no palpitations. He does have diarrhea. He has a lot of complaints. So when you ask about past medical history, he's pretty healthy except for anxiety and depression. And when you look at his med list, Xanax, Paxil, Trazodone, Robitussin DM, he has no drug allergies. He does smoke. He denies alcohol or drug abuse. So you start to do your exam and you get these vital signs. He's afebrile, heart rate 118, BP 150 over 96, respiratory rate of 20. Stop for a moment and take a look at those vital signs. What do you think? Tachycardic, he's anxious, but 118 is kind of fast. BP 150 over 96, that's high too, and he's breathing fast. So maybe it's anxiety, or since things aren't always as they seem, maybe it's something else. So here's the exam: normal cephalic atraumatic, pupils equally reactive to light, but slightly dilated, mucous membrane's moist, neck is supple, lungs are clear, his heart is tachycardic without murmurs, gaps, or rubs, and he has a soft, non-tender abdomen. His extremities show no evidence of trauma. There are good pulses, no edema. He is alert and anxious on his motor exam. Upper extremities symmetric, 5 of 5, so full strength. Lower extremities, he got clonus. They're sort of look like they're seizing almost. And his deep tendon reflexes, I know you guys don't check them mostly. Normal is 2+, his are 4+ in the lower extremity. That means if you tap the knee, the leg jerks and keeps jerking. The upper extremities are a little less than that, but really you tap on the bicep tendon and the arms jump. So something's going on there. Any ideas? I would ask my colleagues, what do you think? And while we're thinking, we're lucky in the hospital, we can buy some time and do some tests that don't help. CBC normal, Chem8 normal, other blood tests not helpful, CAT scan doesn't help, tox screens don't help. So how about a hint? I'll give you a hint. So if you look at this diagram, you see dilated pupils, tachycardia, autonomic instability, so the hypertension. You see tremors, hyperreflexes, clonus, diarrhea, agitation. Does that help? I bet it does. Serotonin syndrome. Round 4 pop quiz. Good luck. So, do you know who the most famous case of serotonin syndrome is? Could it be Walter Mitty, Alex Rodriguez, Libby Zion, or Barry Bonds? Well, you know Walter Mitty, remember, that's a fictitious character with a great imagination. A-Rod, you know him. He did use some performance-enhancing drugs. Barry Bonds, also. Libby Zion, who is she? So lock in your answers. And it's Libby Zion. You might not have heard of her or her case, but her case had a big influence on residencies. She was an 18-year-old woman admitted to Cornell Medical Center in New York City on March 4th of 1984. And she was brought there by her parents. She was very ill. She had a very high fever, 41 Celsius, signs of dehydration, uncontrollable shaking. She had a clear chest x-ray and a white blood count that was elevated. It was 18,000. Normal is just about 11. And she was admitted to a 4-bed ward with a diagnosis of viral syndrome. And the admitting order said routine vital signs. The Zions left their daughter in the early morning hours of March 5th, and they were sure she'd be okay. A few hours later, at 7:45 a.m., the parents got a phone call telling them that she had passed away. And the family assumed there must be some negligence. I mean, you told us she'd be okay. She had a virus. And so they sued the attending physicians, the hospital residents, and New York Hospital. And that brings us to the next question. She was taking an antidepressant, phenelzine. Don't see this used very much anymore. But her death was caused by the administration of one of these medications. Was it Demerol? Was it Haldol? Was it normal saline, or was it morphine? What do you think? Lock in your answer. Demerol. The intern who was in charge of this patient was off the ward doing something else when she went into a cardiac arrest. And she never checked on the patient during the time she was off the ward. The nurses had called her a couple of times saying she's very agitated, and she ordered a posy jacket. You know, those things we don't use anymore because they tie the patient to the bed. There was a lot of conflicting evidence at the trial. One test showed that she had cocaine in her blood. Another one didn't. She had a high fever. She had a sudden collapse after getting the Demerol. So that's what happened. She had not been started on any antibiotics, and her father and mother sued the hospital, as I mentioned. It was a famous case. The father was a reporter for the New York Times, so it got a lot of press, it got a lot of attention. And the grand jury found no evidence of criminal indictment of the physicians, but it did indict medical residents and New York Hospital. There were lots of things that didn't happen, like there was no exam documented in the emergency department by a physician, an attending physician. There were a lot of things. Any case, let's go to the next question. The most significant consequence of the Libby Zion case, not for Libby and her family, but for others. Could it be the banning of phenelzine? Could it be resident work hour limits were imposed? Could it be a $15 million jury award? Or could it be none of the above? So lock in your answers. And you should have locked in that it put limits on resident work hours. There was no big award. There was an award by the jury of $750,000, but they said that half of it was her fault, so they cut it down. And then the net amount after paying interns and everything wound up nothing for the family. So let's go back to serotonin syndrome. It's defined like this. Clinical triad of mental status changes, autonomic hyperactivity, and neuromuscular abnormalities, just like our patient we saw. It's not idiopathic drug reaction. It's predictable when you have too much serotonin. So let's see, this is a diagram that might be helpful. Serotonin is made and put into vesicles in the cell, in the presynaptic neuron, before the synapse, and then when stimulated, it's released, crosses the synapse and hits receptors and activates that next nerve. The serotonin that's in this synapse now gets taken back up by receptors and then put back in vesicles, so it's now turning off the serotonin. Some of this that gets drawn back into the cell gets metabolized by monoamine oxidase inhibitors, so that takes it out. So that's how we prevent us from getting too much. But it turns out that there's ways that we can thwart those things that are there for us. So one of the ways is to take medicines that will increase the amount of serotonin produced. So if you took tryptophan, for instance, that'll make more. If you took amphetamines, that makes more serotonin be released, the more that's been stored. If you take monoamine oxidase inhibitors like phenelzine, that allows less of the serotonin to be destroyed. You also could impair the uptake of the reuptake of the serotonin using SSRIs, those meds for depression. And they're also direct serotonin agonists that stimulate the postsynaptic neurons. And finally, lithium increases the response to serotonin. So there's lots of ways for this to cause trouble. And when it does cause trouble, you can go from mild symptoms like akathisia, that's that restless feeling that people get, I've got to get out of here. You could get some tremors. You can then get altered mental status. Clonus that's inducible means when you tap on the reflex, the limb keeps going. Clonus that's sustained means it doesn't stop. Muscle hypertonicity, where the muscles get rigid. Rigid muscles use energy, that leads to hyperthermia, and now you're in the life-threatening range. So how would you diagnose this? No, I don't think we would do that. I don't think this is going to be one of our future pre-hospital diagnostic tests. So the serotonin syndrome, let me tell you about it. 2004, the report of the Association of Poison Control Centers found that they had received information about 48,000 of these, and a bulk of them were treated in healthcare facilities. 6,700 were seriously ill and 103 deaths. So that's an interesting thing. This syndrome will occur in about 15% of SSRI overdoses. When somebody asked physicians if they knew about this, in 2000 or so, 85% of the physicians didn't really know about it. So how could you get this? Look at the things that are associated with it. SSRIs, sertraline, fluoxetine, you know those drugs, citalopram. Look at the other antidepressants, trazodone, buspirone, right? Those are very common. Monoamine oxidase inhibitors, we don't use those very much, so you probably don't see those. Anticonvulsant, valproate. The analgesics, meperidine, which is Demerol, fentanyl. So you can see, and look under antiemetics, ondansetron, that's Zofran. Metoclopramide, that's Reglan. So there's a load of drugs that we see and use every day. And there are even drug interactions that cause it. So you're on some medicine, and then you add something else. Zoloft, Prozac, Luvox, Paxil, Celexa, Deserel, Buspar, Effexor. Running down the list, Depakote, Demerol, Duragesic, that's fentanyl. Zofran is on the Reglan. So there's a lot of things, and you can see the list there. So how would you diagnose this, I asked? This is one way to do it. So if you follow this, they ask you, are they on medicine that has something to do with serotonin? If the answer is yes, then you look for any one of those symptoms there or signs. And if anyone is present, then you have to think that's it. If they don't have any of those symptoms, then you're done. So what do we do for this poor man? We stopped the things that precipitated it. We did generally supportive care, controlled agitation. It's possible to give a 5-HT2A serotonin antagonist. That'd be a medicine, cyproheptadine or Zyprexa will do that. Thorazine can do that as well. We gave him some Ativan to calm him down. His blood pressure came down. We made sure that his temperature didn't get too high. And he did very well. He was better within 24 hours and discharged home. So his problem was they increased one of his psych medicines. His PCP added an antibiotic to him and Robitussin. And that cocktail increased the serotonin, and that was it. So if you're on any of those medicines, which are legion, they're all over the place, and something happens, you have to think about this thing. So the pearl for this, and I think for us, consider serotonin syndrome in patients who are taking psych meds and have strange muscle symptoms. I think That's enough for us to say, what about that serotonin thing? And we could look up the rest. Once again, we'll hold questions to the end. And here's case number 4, possible stroke. A lot of pressure on us for stroke. The clock is ticking, everything is measured, and the consequences are bad for the patient if we do the wrong things. So EMS is dispatched to a report of a possible stroke. She's a 72-year-old female who became suddenly weak while working at the local pharmacy. She says she couldn't move her legs, she had to sit down. They would not move. There were no prior episodes. She didn't have headache, she didn't have blurred vision, speech abnormalities, no loss of consciousness. She has a history of hypertension, spinal stenosis, type 2 diabetes. She's had TIAs. Here's her med list: lisinopril, hydrochlorothiazide, glipizide, and aspirin. No drug allergies. And let's look at the exam. She's afebrile. She's a little anxious. Her heart rate's 86. BP 156/74. Respiratory rate's 14, non-labored. Anything concerning there? Those look pretty good, right? Let's examine her. Normocephalic atraumatic. Pupils equally reactive. There's no JVD. Her lungs are clear. Heart's regular. Abdomen's non-tender and soft. Extremities have good pulses. And we do the neural exam. She's alert and oriented. Pupils are equal. No facial asymmetry. Upper extremities are strong and equal. Lower extremities are weak, with the left being less weak than the right. The Cincinnati Stroke Scale, speech was clear. There's no facial droop, no pronator drift. What now? There are stroke mimics. So this is the most famous one, right? And you guys have the treatment for it, so you check the glucose. It's not that. You look at their pulse ox, and it is fine also. So your presumptive diagnosis at this point, stroke, maybe? Which brings us to the next round of pop quizzing. Here you go. Which stroke syndrome affects legs more than arms and face? So this one affects the legs more than the arms and face. And the choices are anterior cerebral artery, middle cerebral artery, posterior cerebral artery, or none of the above. We typically don't teach this to EMS folks. It's kind of an interesting thing. If you don't know, lock in your answer and make a good guess. And you should have guessed anterior cerebral artery. They get leg greater than arm. They do have sensory effects that go along with that. They can be confused, sometimes incontinent. The middle cerebral arteries are the ones in which arm and face are more highly affected than legs. And these are folks who may get visual field cuts. They may have dysphagia and agnosia. And then the posterior ones, that's in the back, and that can also have visual field cuts, but also have unequal pupils, visual agnosia where they don't recognize things they see, altered mental status. If it's vertebral base or way in the back, those are the folks who get vertigo, nystagmus, dysphagia, those type of people. So let me ask you a little bit more about strokes. What percentage are ischemic? Is it less than 15? Is it 25? Is it 65? Is it 85? What do you think? These are the ones who get TPA'd. So lock in your answers, and the correct answer is D, 85%. So most of the strokes are ischemic, and we have treatment for ischemic strokes. So we're kind of lucky that way. So now I want to ask you something about TIAs. Which of the following score the most points on the ABCD squared TIA assessment tool? You might not have heard of this tool, but this tool was developed to help physicians think about TIAs as a very serious problem, as an indicator that the patient's at risk of a stroke. Most of the items get 1 point, some get 2. So is age greater than 60 a 2-pointer? Is a speech disturbance without weakness a 2-pointer? Is C, duration of symptoms 60 minutes a 2-pointer? Or is diabetes? So when we're making our guess here, lock in your answer, and you should lock in this one. 2 points for 60 minutes of symptoms and unilateral weakness. The others are 1. So back to the program. Here's what the ABCD squared tool looks like. I don't think you really need to know this, but here's the idea of it. 60 gets a point, systolic blood pressure of 140 or diastolic of 90, a point. Unilateral weakness without speech is 2 points. With or without speech weakness is 2 points. Speech by itself is 1. Duration of 60 minutes is 2. 10 to 15 is 1. And diabetes is 1. You can get 7 points. And this graph shows us the distribution or the stroke risk for 2 days, 7 days, 30 days, and 90 days. And I don't think you need to know these numbers at all, but look how the higher score is more associated with having a stroke. So if the patient is having a TIA, some of them will have a stroke, and some of them will have a stroke in 2 days. So important to do the right thing. When people created this tool, they had this idea that if you had a low score, 0 to 3, the 2-day stroke risk was about 1%. So maybe that patient could do their workup as an outpatient, unless they had a new high-risk thing like AFib. If they had a moderate score, 4 to 5, there was a 4% 2-day stroke risk. And so observation in the hospital was a good idea. If it was 6 or 7, they were 8%. That's 1 in 12 we're going to have a stroke in 2 days. Definitely admit. Now these numbers might not have actually panned out for a future look and everything, but the idea of longer TIAs, meaning higher risk, is important. So the initial evaluation is within 12 hours, complete it within 2 days. So the hospital is a really easy place to do that because we get 75% of it done in the emergency department. We do labs, we do EKGs, we do imaging of the brain. We usually start with CTs because they're fast, and later, before they go home, it'll be an MRI. And then we're going to image the vascular of the neck. So these days, it's mostly done with CT angiograms of the blood vessels in the neck and head because folks figured out how to grab huge clots out of the large vessels. So that's what's done. Antithrombotic therapy, since these are ischemic and related to clots, usually aspirin is the one. Sometimes they add Plavix. Sometimes they add dipyridamole plus aspirin. That's called Agrinox. If it's cardioembolic, like AFib, then they need to be on Coumadin or those new novel anticoagulants like Eliquis and Pradaxa. Then blood pressure is managed. They take a statin drug to lower the cholesterol. If they smoke, they initiate smoking cessation, get the blood sugar under better control, and get the patient more active. There is some surgical management of the carotid arteries. If they're 70% or higher, they open those up. If they're 50 to 69, that's not commonly done unless you're at a center that does those with a very low complication rate. And we still don't bypass the brain, although I'm sure you can think of many politicians who seem like they're bypassing their brain. Anyway, EMS treatment, you probably would do this, oxygen, IV transport, frequent reassessments in the emergency department. We do that NIH stroke scale, 3 points for weak left leg and left leg ataxia. She couldn't touch her knee to her heel to her knee and run it down the shin well. She goes off to the CT scanner. The NIH score is low, so she's not going to get TPA. Talk to the neurologist, and they say, yeah, do a scan through the LS spine too, since both legs were involved. And now we're waiting for results. So it's now 45 minutes since last at baseline. Those vitals haven't changed very much. Blood pressure is a little high. That might be okay, though, if you're having an ischemic stroke. Maybe we need a little more pressure to get blood into that area of the brain that's affected. Her physical exam while waiting for results, her pupils equally reactive, no JVD, lungs are clear, heart's regular, extremities have good pulses, 1+ pulses, pardon me. The neuro exam is not changed, and then we get the results. Quickly look. We don't take that short a time, but there's no hemorrhage. And she has chronic small vessel ischemic changes. This is what happens as we age. The blood doesn't flow as well through those tiny vessels. The reason for doing CAT scans for stroke patients is that strokes are a clinical diagnosis, and if we're going to give TPA, we don't give it to people with brain tumors or bleeding. So the CAT scan is really done to look at those. The LS spine, lumbosacral spine CT, Didn't find any acute injury to the spinal cord or any disc disease. So we talked with neurology again. They don't change their recommendations. Don't do TPA. Start her on Agranox because she was on aspirin. So Agranox. While we were awaiting admission, I keep checking on the patient, and the leg's getting better, except she has more weakness at the ankle joint. So is this a problem? Is anyone worried? Why would we worry or not worry? So you ask the doctor for the answer, and he doesn't have the answer. So we have to come up with an answer. So I had an answer, and I called the right person, and that person was very helpful. This patient had peripheral artery disease, and that's one of the images of the artery coming down behind the knee, the popliteal artery, and you can see that it seems to cut off. Right here, nice thick artery coming down, and then nothing. Sudden occlusion of the artery. So she wound up getting that fixed, and you look at the difference. Let's look at the difference side by side. So that's a phenomenal thing. You can see normal blood flow would be able through there. So let's go to round 6 of our pop quizzes. Which of these are not part of the 6 P's of limb ischemia? I'm sure this is something every school child knows in kindergarten. The 6 P's: pain, pallor, perishingly cold. Somehow that sounds like a British soft drink, perishingly cold. Or are all of those part of the P's? What do you think? If you had limb ischemia, would you have pain? I think that's probably part of it. Would you have pallor? Would it be pale? That sounds like that could be part of it. Could it be cold? And you have to put perishingly on it because you don't have 5 P's and a C. I think you know the answer. You're locked in choice D. They're all part of it. Pain, pallor, pulselessness, paralysis, paresthesia, and perishingly cold. By the way, the pulselessness is a very late sign. So other things ahead of it are more likely. So now we talk about emboli. This embolism that happened, it traveled to her leg, had to come from someplace. Did it come from the heart? What percentage of peripheral emboli originate in the heart? Is it less than 15? Is it 40? Is it 80? Is it 95? What do you think? Lock it in. It's actually 80%. That's why lots of people with strokes get an echocardiogram to look for those clots. So she went actually to the tertiary care hospital. She was heparinized, and they restored the blood flow. So excellent. So the pearl here, I think, is to remember that 20% of those who we believe are having a stroke are not having a stroke. They're having a stroke mimic. So we want to be thinking about those mimics as we're moving our patients towards the CT scanner and towards TPA. And the other pearl is that some people who have a TIA are going to have a stroke in the next 2 days. So let's consider it a neurologic emergency. So I have one lightning case as I only have 3 minutes left. See if you've seen this one. 26-year-old male undergoing bronchoscopy as a research study developed sudden dyspnea and cyanosis. So there it is. He's blue. He's unemployed. He was well until this happened. No medical problems. No meds, no allergies. Your physical exam, he's tachycardic, tachypneic, and hypoxic. But he has no JVD. His lungs are clear. What is it? So you put him on oxygen and continuous pulse oximetry, and the pulse ox doesn't budge. Rapid transport. He gets to the emergency department, still 80% pulse ox. What's the diagnosis? He didn't know. She didn't know. He wasn't sure. He got it. And it brings us to the last round of pop quiz, the lightning round. The amount of hemoglobin that must be unoxygenated to produce cyanosis. Is it 2.5, 5, 7.5, or maybe all of those? We have about 15 if we're a normal, healthy person. What do you think? Turns out you should lock in choice B, 5 grams %. So you would lose 1/3 of your oxygen carrying capacity before you turn blue if you started with 15. So which of these patients will not likely turn cyanotic then? Is it a carbon monoxide poison patient? Is it a profoundly anemic patient? Is it an asthmatic patient? Or is it all of them? What do you think? Lightning round means lock it in. It's all of the above. CO poisoning, those folks are pinkish. Profoundly anemic means they have less hemoglobin. So let's say they have 7. In order for them to turn blue, they have to deoxygenate 5 of them. So that's not so likely. And most of your asthma patients have good pulse oxes. So that was the case. It was methemoglobinemia. It's an abnormal form. It doesn't carry oxygen. Lots of drugs and chemicals can cause it. And the treatment is bizarre. You give methylene blue. They're already a Smurf, and you give them a dose of this. It fixes the hemoglobin. So this is one of those things to think about. If they're cyanotic and they don't respond to oxygen, think about that, bring it up, and that'll be maybe get the emergency department to think of it quicker. So finally, shutting down now. How do we avoid errors? We have to think about how we make decisions. I would say this is a biased representative error. This case is like every other case I've seen lately. That one with the Tylenol looked like every other case. Confirmation bias. We stop looking once we find the answer, and we don't pay attention to the evidence that tells us we're wrong. There's search satisfaction error. The first obvious thing, we stop at that, the stroke. We don't think about the vascular injury. And attribution errors. You don't like that patient. He's smelly. His colostomy bag has fallen off. He's got stool on him, and he wants to reach out and touch you. So we don't provide good care for them. Any negative stereotype, we're at risk of not doing the right thing. And we should always, like we did in these cases today, think what's the worst possible thing. If you want a really cool book to read, How Doctors Think Is It. I want to thank you for everything today. I want to thank you for all your work you did during this pandemic. You were the folks who stepped up each and every day, even when you didn't have everything you needed. And you're still after trying to do things better, always learning. That's a great group of folks, and I'm proud to stand with you. Thanks for coming today.
Thank you, Dr. Traynor. Unfortunately, we're out of time. Dr. Traynor's handout will be available for download on his speaker profile, and you are able to download it now or by the session description. If you have any additional questions for Dr. Traynor, send them in, and we'll get you the answers.
The number one job of an elected official is to be able to communicate, and to have that taken from me would have been catastrophic. In July of this year, a neurologist said to me, "We've discovered a very large mass inside your brain. It's not something we can even remotely consider operating on here. You've got to find somebody that can do this. There's a very good chance you're never going to be able to speak again." What good is a mayor if you can't communicate? I had talked to doctors in Boston, some of the best hospitals in New York City. More than one physician pulled me aside and said, "There's only one guy that can do this surgery in the world, and it's Dr. Robert Friedlander at UPMC."
What's special at UPMC is the combination of the very best technology and very expert hands to be able to take care of these complex tumors.
I think I've said it before, of just how grateful I am to be alive. I'll never forget it. Look, I didn't choose to have a brain tumor, but I did choose UPMC.